Dr. Hazel Baconga from the Philippines, and I'd like to present my pilot study entitled Diagnostic Performance of Brain Natriuretic Peptide, Bioelectrical Impedance Analysis, and Left Ventricular and Diastolic Diameter in Determination of Fluid Overload and Mortality with Pediatric Sepsis. So this will be the outline of my presentation. So infectious disease ranks among the top causes of child mortality in the Philippines. The studies have shown that fluid overload in pediatric sepsis leads to increased risk of mortality. Now there's a trend towards point-of-care modalities to predict clinical outcomes. These were the modalities that were tested in this study. So BNP is a serum test that is used in conditions such as congestive heart failure. It's to check if there are ventricular stretching. For left ventricular end diastolic diameter, in the pediatric population, we use the z-scores to obtain standardized values. Bioelectrical impedance analysis is a method for estimating body composition such as water, fat, muscle mass using a weak electrical current. Currently, there is no consensus as to a standardized method to assess fluid overload in the pediatric population. So the general objective of the study is to determine the diagnostic performance and prognostic values of BNP, bioelectrical impedance components, which are the total body water and absolute fluid overload, and left ventricular and diastolic diameter, with the clinical outcomes and possible fluid overload in pediatric sepsis and septic shock. So this is a prospective observational cohort pilot study conducted at a tertiary public hospital in the Philippines. Patients more than 28 days old to 18 years old who presented with sepsis at the emergency room on admission were included. The entire spectrum of the manifestations of sepsis were included in the study. So diseases and states with abnormal body fluid regulation were excluded. Eligible subjects were recruited as they were admitted to the emergency room. The principal investigator was not the primary healthcare provider for the patients and served as a researcher only. If the patient needed resuscitation and emergency care, these were done first before proceeding to discuss the study involving the patient. Diagnostics were taken on admission and on the third day for monitoring. So these were the following possible causes for withdrawal from the study. So descriptive statistics were used to summarize demographic and clinical characteristics of patients. So sensitivity, specificity, negative predictive value, and positive predictive value were used to determine diagnostic accuracy of clinical outcomes. Cutoffs were evaluated using receiver operating characteristics curves. Pearson product moment correlation was used to determine the linear correlation with fluid overload. All statistical tests were two-tailed. Shapiro-Wilk was used to test the normality of the continuous variables. Missing values were neither replaced nor estimated. Null hypothesis was rejected at 0.05 alpha level of significance. Stata 13.1 was used for data analysis. Expired patients and survivors had similar baseline demographic and clinical characteristics. 3 out of the 22 patients expired. The mean Glasgow Coma scale of the expired patients was significantly lower. There was a difference from the sources of infection between the expired and surviving patients. All expired patients had used vasopressors. The median diastolic blood pressure of expired patients was much lower. There were no significant differences in the cumulative fluid balances and percent fluid overload between the two groups. The serum albumin of the expired patients was significantly lower. The median BNP levels on admission were comparable. However, the day 3 BNP and subsequently delta BNP levels were much higher in the expired patients. There were no significant differences in the bioelectrical impedance analysis between the expired patients and the survivors. The echocardiography parameters were comparable on admission. Left ventricular and diastolic diameter on day 3 z-scores were significantly lower in expired patients. Delta BNP, day 3 total body water, and day 3 left ventricular end-diastolic diameter were significantly correlated to the cumulative fluid balance. Pertinent diagnostic performances are shown in the next two slides. A BNP level of above 670.34 picograms per milliliter is excellent for predicting vasopressor use, while a level above 1211.86 picograms per milliliter has high specificity for predicting mechanical ventilator use. A delta BNP level above 5388.30 picograms per milliliter has 100% sensitivity in predicting mortality. And LVEDD on day 3 with values below 20 millimeters had a high sensitivity in predicting mortality. Point-of-care testing of children at the emergency department and subsequent monitoring may direct clinicians to focus efforts on timely interventions. This validated feasibility in the critical care setting. Out of the recruited patients, the expired patients had more severe infections. Judicious fluid therapy might have played a part in the lack of overload states. The study confirms the findings that the BNP is elevated in pediatric sepsis. The expired patients did not have significant fluid overload. However, day 3 BNP values were significantly higher, suggesting a different mechanism that is not related to myocardial ventricular stretch from fluid overload but possibly underlying organ damage and may be indicative of fluid non-responsiveness. Out of the 3 diagnostic tools that were tested, LVEDD and total body water in bioelectrical impedance analysis had directly strong correlations to cumulative fluid balance and can be used to monitor hydration status. There was a disparity of our results from a similar study done in adults with sepsis. Our study had increased BNP values despite no difference in fluid overload, whereas in that study, there was noted increased BNP values attributed to fluid overload. So in conclusion, BNP is shown to be significantly elevated in non-survivors, with third-day BNP levels shown to be better predictors of mortality, independent of fluid overload. It appears that the rise in BNP levels reflects cardiac dysfunction because of severe sepsis and could be a measure of fluid non-responsiveness. LVEDD and BIA are good estimates of cumulative fluid balance, but not as predictors of other clinical outcomes. Thus, the utility of these tests is limited as a guide to fluid therapy. Significance of the outcomes of this study was limited due to the small sample size. The limitations we encountered was a small sample size, and another limitation is the availability of equipment for BIA and echocardiography, which may not be available for all institutions. However, their portability and non-invasive nature make them excellent adjuncts in managing patients. Thank you for listening.